Welcome to See You Now. I'm Shauna Butler. As September, National Suicide Prevention Month, comes to a close, we wanted to revisit our episode on the mental health pandemic that originally aired in May of 2020 as part of National Nurses Month. Each year, during the month of September, the Suicide Prevention Lifeline and other mental health organizations around the world raise awareness of suicide prevention. And on October 10, we will observe World Mental Health Day, a day focused on raising awareness of mental health issues and mobilizing efforts in support of mental health. Mental health is one of the most neglected areas of public health. Close to 1 billion people are living with a mental health disorder. 3 million people die every year from the harmful use of alcohol, and 1 person dies every 40 seconds by suicide. And now, with billions of people around the world affected by the COVID-19 pandemic, we're seeing a further impact on people's mental health. So now is the perfect time to reflect on not only our own mental health, but that of our loved ones and our friends and our colleagues, as we all try to protect our mental health and cope with the uncertainty of a pandemic. It's more important than ever that we be there for each other, be proactive in taking care of our mental health and well-being, and take steps to prevent suicide, and to know it's okay to not be okay. This special episode focuses on the mental health of nurses during this pandemic. Listening back, it's a profound reminder of the lingering and potentially long-lasting effects of this pandemic. As we focus on mental health and suicide prevention, it's incredibly important to remember that taking care of our frontline healthcare workers, yes, nurses, and also pharmacists, patient transporters, registration secretaries, security officers, respiratory therapists, physicians, clergy, housekeeping and maintenance crews, and nutrition teams, a big family and village, is crucial. Without them, our health systems simply cannot function. When they are healthy, we all benefit and we are all safer. Thank you for listening. It's because of all of you who are listening, subscribing, and sharing See You Now with your friends that we're able to build awareness and energy around identifying the tools and the innovators prepared and ready to lead us toward a healthier today and tomorrow.
See You Now is a podcast highlighting the innovative and human-centered solutions that nurses are coming up with to solve for today's most challenging healthcare problems. Created in collaboration with Johnson & Johnson and the American Nurses Association, and hosted by nurse economist and health tech specialist, Shauna Butler.
Honestly, I don't think we were prepared for this.
It's extraordinary, this virus. I've never experienced how rapidly devastating this is.
Right now, nurses are pushing through. It's when things start to die down that it really starts to hit you.
We have a responsibility as a nation, and certainly leading from the healthcare community.
We have to make the mental health of the workforce a priority.
And it can't be one and done. It can't be, when the numbers go down, everybody will be fine.
The good part is there are things we can do if we just take action.
I'm Shauna Butler, and this is See You Now. No one anticipated that the Year of the Nurse and the Midwife would see nurses at the center of a novel coronavirus pandemic. But that's exactly what's unfolding, and nurses are rising to the challenges and demands. Every day, frontline healthcare teams are making impossible choices, working in unimaginable and exhausting circumstances, risking their health and their families' health, saving lives, keeping our health systems afloat, and being exposed to patient death rates that, quite frankly, have shocked and saddened the world. The work is exhausting on every dimension and triggering a series of pandemics. COVID-19 will have a mental health impact on everyone, especially on those providing the care and making tremendous sacrifices for our communities. As we come to the close of National Nurses Month, See You Now wanted to devote a special episode to addressing the mental health and well-being of nurses. We begin with a visit to the ICU for a detailed clinical look at what it's like caring for COVID patients. We explore the moral and ethical dimensions of this pandemic, and we ask how to best support the mental and emotional well-being of healthcare workers and what that means in terms of reshaping everything from our educational systems to our workplace culture and our social norms.
What all of the nurses that I work with would want me to share with you is to appreciate that we are not allowing your loved ones to suffer alone or to pass this world and to die without someone near them. My name is Barbara McLean. I am a clinical nurse specialist and a nurse practitioner. I am considered an expert hemodynamicist, which is an expert in hemodynamics, the way your blood flows and the way you utilize oxygen. On February 27th of 2020, my husband and I were on our way to Selma, Alabama, and we were about 20 minutes outside of Atlanta. And my colleague, who is the chief of infectious disease, called me and said, "Barbara, I think we have our first patient with COVID, and I wondered if you could come in to help." I was tagged as the clinical leader for the hazardous infectious disease unit. And the main reason that I was the clinical lead is that I do a fair amount of disaster work. So when the doctor called me, I just said to my husband, who's pretty used to these kinds of things, I said, "Oh, we have to turn around. We're not going to be able to go to Selma. I have to go back to the hospital." And I called one of my colleagues from my hazardous infectious disease and said, "Would you be willing to share care with me for this patient who we believe has COVID-19? And this was very early. So this was February 28th. We hadn't had any other patients. So testing was very rigorous. And at that time, it was only being done by the CDC. So we took this young man. He was very young, 23. And along with my colleague, he and I actually shared the care for this patient for 6 days straight on 12-hour shifts. So this young man, he had a terrible time breathing. He was really struggling. And we can't even imagine what that's like, because not like scuba diving. It's really like being buried under 6 feet of dirt or drowning. And he was so hot, he would say, "Oh, Miss Barbara, I can't open my eyes. I can't open my eyes. I can't move." And it was agonizing, actually, to see this young man who was in so much discomfort and breathing so fast and having such a severe temperature. But we improved, and after 6 days, we moved heaven and earth to get him sent home once we got his test back that he was negative. That was our first patient, February 28th. From that point, we just had an evolution rolling up of patients. There were days in our emergency department that every bed in the emergency department was a patient under investigation. Many of these patients deteriorate very quickly. So they go from being, "I don't feel well, can you drive me to the hospital," to the next day having a tube that is down to their trachea and helps us to supply them with air. That's called mechanical ventilation, intubation, and to being unconscious. So every day things are changing, and we were all learning every day more and more and more. I would have to be comatose, in a coma, not to be afraid. Of course I'm afraid. I am afraid. I have a brand new grandchild, my first grandchild, who was born on April 2nd during the COVID crisis. I want to hold him. I want to be able to kiss him. I can't do that right now. Just like everybody else, we can't do those things, those normal things right now. The thing I'm most afraid of is actually that I'll never have a chance to kiss him. But we can't allow fear to inhibit what we have to do. And I really appreciate that this is not the only pandemic, that there's an unemployment pandemic, that there's an isolation pandemic, that there's a loneliness pandemic and a depression pandemic and a domestic violence pandemic. And all these things have increased significantly since we started social distancing and isolation. I really appreciate that. And I appreciate we have to do whatever we need to do to overcome this and to overcome all of these pandemics and try to do that all at the same time. But the only way we can overcome the viral pandemic is to be safe. It's extraordinary, this virus. I've been a critical care nurse for 45 years. I've done disaster work all over the world. I've never experienced how rapidly devastating this is. We have nurses that have taken care only of COVID-19 patients since March 1st. Every day they come in to that unit, and to come into the hospital, they have to wear their special mask, the N95. We wear a mask cover, we can barely breathe. We come in to our intensive care unit, and we're taking care of critical patients in this very extraordinary equipment. Physical labor involved with caring for someone who is acutely or critically ill is already very exhausting, especially with COVID-19. And that's on a good day. We're wearing a whole nother layer of clothing, a mask that is designed to keep any air out. It's only the filtering of the air. And on top of that, another mask and a face shield and a bonnet and shoes and 2 pairs of gloves. Within 15 minutes, you feel exhausted. You're sweaty. You feel like you're not breathing. And you're doing very physical work. And we are applying science. We're doing research. We're holding their hand. We're rubbing their heads. We rub their feet. We make recommendations about what has to happen with the ventilator. We're notifying our physicians. We're calling to our colleagues. We need pain medicine. We need fluids. We need this. We need that. And we're doing all of this science. But we're also the family in the room. We're mamas on the ground. We're papas on the ground. We're sisters and brothers and daughters and sons to the people you love. And while you experience this, we are also experiencing this. And your experience is so profound because you can't see your mother. And when your mother passes, we're there with your mother. And then we go to the next room. And we're with your next door neighbor's brother when he passes. And then we go to the next room. And we're with your sister who's getting better. But every day, you can imagine, on top of the physical work of being an intensive care nurse, or any nurse in this crisis, or actually any nurse in any time, we certainly expect to care for critical patients. We rise to the challenge of caring for critical patients with hazardous disease, knowing many of my colleagues live in a trailer, stay in a hotel, have sent their families somewhere else. They don't have their families with them. We certainly expect to do all these things as part of our job. And it's not even really a job, it's a commitment. It's part of our commitment. What we didn't anticipate, and what I don't think we're prepared for, and I think what we're struggling with now and probably for years to come, is doing this all alone with a person who is dying all alone. And the process is a stunning spiritual, emotional, mental journey that you can't even imagine. I can't even really share that with other nurses or other doctors who aren't doing exactly what we're doing. They understand it because they bear witness to suffering, and we do it all the time. It's part of what we do. We also bear witness to joy. And in the beginning of this, we didn't have much joy. It was mostly suffering and sorrow and loss. Excuse me. And I wouldn't be representing well if I didn't tell you that the nurses and physicians and therapists and others, physical therapists, environmental services, everyone, the people that I work with, they want you to know that they are really suffering. They are suffering. And we're so grateful. We're so grateful because our communities have gathered around us, and people clap at change of shift and hang out signs and send us food and do all these incredible things. And every tiny little thing, some little card that a 5-year-old drew that comes to us, all of that is so incredibly meaningful. And it has helped us so much. But I'm going to tell you, we are not suffering like the families are. We are not suffering like our patients are. And we are totally in honor and in awe of that and are respecting that. But we are really suffering. And we overcome that every single day. I want to again say to you how grateful we are for the knowledge and education and support we've received and we've earned and we continue to earn as nurses. How lucky we feel even in our sorrow and our exhaustion and separation from our own families. How grateful that we are that we can be there for the people that you love in these moments.
Barbara McLean is a clinical nurse specialist and clinical leader for the Hazardous Disease Unit at Grady Health System in Atlanta, Georgia. She has been on the front lines in disaster relief care in Haiti, New Orleans, Nicaragua, and wherever first responders are needed. Her expertise is highly sought after, and her knowledge and insights, especially in hemodynamics and management of critically ill patients, are invaluable right now. Every day, nurses face difficult decisions and ethical dilemmas. Nurses know how to deal with suffering. They're accustomed to seeing trauma and pain. But this pandemic has brought up things no one was prepared for. We asked Liz Stokes, the director of the ANA Center for Ethics and Human Rights, to provide insight into the ethical and moral dimensions of the COVID-19 pandemic.
My name is Liz Stokes, and I am the director of the American Nurses Association Center for Ethics and Human Rights. I am a nurse first. I have many different professions. I'm also an attorney. I'm also an ethicist. I am always a nurse first because nursing was my foundation, and that was the rock that got me to the different places and the different steps where I am today. The Center of Ethics for Human Rights started from inquiries from nurses around the world that wanted guidance on how to deal with all of these emerging ethical issues that were happening in the world. 30 years ago, we were dealing with cloning and Dolly and HIV, and there were a host of ethical issues that we had no guidance for, and the ANA Center for Ethics and Human Rights was created.
What about the human rights part? Nursing has such a long-standing tradition and history of being the defender of human rights.
Absolutely. And one of the foundations of our code of ethics is that nurses advocate, preserve, and protect the human rights of every individual. And that's something that's the foundation of everything that we do. All of the policy, all of the documents that come out of the Center for Ethics and Human Rights are founded in this preservation and protection of human rights.
And people don't necessarily think of the intersection of nursing and ethics. But there is no better place for all of humanity to present itself and to manifest itself in its beauty and its mess than in a clinical environment. I think nurses are in a unique and interesting and important position to speak to the ethics of this because they really understand those lived experiences, those lives, the sensitivities. Your thought on that?
If I had a bullhorn, I would go to the rooftops everywhere and shout this. I'm very passionate about this, and I wholeheartedly agree with you, Shauna. Nurses are so incredibly well positioned to deal with these ethical dilemmas because we deal with everyone. we are not able to say, well, I don't want to take care of that patient, or I'm not going to take care of this patient, or this person doesn't have any insurance, or this person doesn't have coverage. We care for everyone, and we care for everyone without bias, without judgment. We give them 100% of our compassion and 100% of our skill. And I think because of that, we are exposed to so much. We are exposed to many different types of patients who are living in different worlds, and we're able to have those experiences enrich us and help shape our future practice.
Yeah, and there's never been such a moment of such grand and rapid transformation as what we've been experiencing during COVID. I think all of us are really glad to know that there is a Center for Ethics and Human Rights. What has COVID done for the questions that are being asked and maybe how they're answered, or the pace at which they're answered?
One of the most significant ethical issues that has arisen, and honestly, I don't think we were prepared for this, is how do nurses weigh the risk of their own personal health, their own personal safety, and possibly exposure to their families or their loved ones? How do nurses weigh that risk with their professional obligation to care for patients? This is what nurses do. This is a pandemic. Many nurses are eager to go out and to fight this pandemic and to care for patients and absolutely put their heart and soul into everything that we can do to save people from this pandemic. At the same time, because they're in such hazardous conditions, they're really risking so much of themselves and so much of their families in order to do that. And we get tons of emails from nurses around the world that are reaching out to us to say, I need ethical guidance on this situation, where nurses are really afraid to go to work. They're afraid because they don't have enough PPE. They're afraid to go back to their homes. They may have young children or elderly parents, and they're not sure what to do. They're not sure if I stay or do I leave, do I quit? And so they're really seeking guidance and help to help make these decisions.
There's such a range of circumstances that they find themselves in. And I think one of the long-term consequences of all of these issues is moral injury.
Yes.
Explain that and where we're at risk for experiencing that.
When we look at nursing traditionally, nurses are already exposed to moral distress, exposed to compassion fatigue, burnout. There's a host of negative psychological consequences related to nursing. Healthcare has changed drastically over the course of several years. And when we think about the issues related to staffing, or the issues related to resources, or the issues related to nurses being prevented from providing the care that they want to deliver, that's what causes moral injury. When we're facing this COVID-19 pandemic, it exacerbates a whole host of emotions. If you're thinking about a nurse risking his or her own personal safety, but then also the physical conditions that they're working in. So they're working in a mask, they're working in a face covering, or they're working in these really hot gowns, and they're sweating and they're hot. I had a nurse talk to me last week, and she said, I was so hot underneath this mask that I had anxiety and I couldn't breathe. And then I thought, oh my God, do I have COVID? So it's like, there's all these components. So you compound all of those physical things with underlying nurses don't get enough breaks. They don't get to have their meals, which is kind of the traditional nursing issues that happens. You combine all of that. Now you're wearing a suit, and now you're dealing with this tremendous emotional aspect of COVID. Patients that are really, really sick, and they're really, really sick fast. And I think when we're looking at the full trajectory of this, we have a host of patients, right? There are hospitals that have hundreds of incredibly sick COVID-19 patients, and nurses are dealing with this. Nurses are dealing with patients that are passing away without their families, and nurses are there beside the patient at their last breath. And the emotional toll combined with the physical toll is absolutely unimaginable. And so when I think about moral injury, I think about right now nurses are pushing through. It's similar to battlefield medicine when you're in the front line and you know that you have a war in front of you and you know you have to continue and fight through to get through this to get to the other side. It's when things start to die down that it really starts to hit you. And I think this is what's going to happen to a lot of nurses.
On a daily basis, I need to be outside and I got to go walk. And during that walk, I just give myself permission to just cry, to just have the sadness wash over me. And I'm not in those same places with ICU nurses and nurses in nursing homes and the labor and delivery nurses and oncology who are helping people through all of this. I think it's important for everybody to know that what they might be feeling is moral injury, and they're entitled, I guess, is the way to be lenient with themselves, to say, how do I, that's that guilt that comes with, well, why should I be feeling this? I wasn't there. How do you help people think about that so that what's the language as an ethicist? What is that conversation in that script to help people identify what it is that they're feeling so that then maybe they can manage and cope with it?
I had a nurse contact me and was feeling tremendous guilt over quitting her job. She felt tremendous guilt because she was leaving her friends and her colleagues. She felt tremendous guilt because she was leaving her patients. She was really incredibly good at providing one-on-one care, providing end-of-life care, but she felt that the risk for her own personal safety and her family, she had young children, was too great. And I asked her, what was the response from your colleagues and from your support system? And she said, I have been supported. And that is the key message, is that we have to support everyone in these efforts. Regardless of what your decision is in this pandemic, everyone is contributing in some way. Even in these really difficult, heart-wrenching decisions that nurses have to make each day, they must be supported because she's no longer at the front line. But as you mentioned, that guilt or that feeling of, I'm not with my colleagues, I left my colleagues, I left my patients, that in itself is a heavy, heavy feeling. And letting her know that she's supported in her decision, that was the ethical balance that she made, and that was okay. That was the right decision for her. It may not be the right decision for someone else, but it was the right one for her, and that she should be at peace with that.
There are instances where nurses on an individual level are struggling with situations in their health systems. What are you doing for that individual nurse? How does the ANA work with them?
I think it's really important when we talk about ways to address the emotional piece, ways to address the problems within an organization with an individual nurse. I think it's really important to help nurses recognize often these are systemic issues. And so we'll say to the individual nurse, this is a systemic issue. You are not by yourself with this. And so providing nurses with the resources to go back to their organization to say, hey, did you know ANA has a policy related to this? Or did you know ANA is doing legislative action to change these things? I have heard and I know make a tremendous difference. So I'm thinking even outside of COVID, when nurses contact us related to specific things, I will give nurses ANA policy and they'll take that policy and they'll go to their nurse manager and they're like, look, ANA says this, we should be doing this. And I think it goes a tremendous way. I also think it's really important that we don't try to place the onus on the individual nurse for systemic issues. And that seems to happen a lot when we talk about resilience issues or ways that nurses can help their emotional or mental well-being. And that's like, oh, nurse, you should go to sleep, get enough rest, or get enough food. That's an important component, but it's such a small component of what's so much of a bigger issue.
Liz Stokes is a nurse, attorney, and ethicist, and the director of the ANA Center for Ethics and Human Rights. I'm Shauna Butler, and this is See You Now. As nurses and other healthcare workers struggle to make sense of the moral and ethical dimensions of this pandemic, the working conditions, the sorrow and loss, the separation from their families and loved ones is taking a huge toll on their mental and emotional well-being. There's a mental health pandemic that has been sweeping across the healthcare community for years now, and the effects of not taking giant leaps to address it will be catastrophic. Nurse scientist Judy Davidson calls our attention to the mental health risks and even grave consequences of being in healthcare, and what works to save the lives of those who have dedicated their lives to saving others.
My name is Judy Davidson. I am a nurse scientist. I was born and bred as an ICU nurse, then became a clinical nurse specialist, worked in and around the ICU for 25 years, then managed an ICU, and after that went back for my doctorate in nursing. Throughout that entire time, since the mid-'80s, I've been conducting my own research, first on clinical topics, things that just piqued my interest. Then I went into family-centered care, conducted research on how to work with families of critically ill people to prevent issues like post-traumatic stress, anxiety, depression amongst the families of critically ill. And then something changed. At work, we had a series of suicides, nurse suicides, and that really shifted my whole life from that point on. I went to the literature. I said, how could we have more than one? That's really unusual to have more than one suicide of a nurse in a year. And I said, how much is too much? And I went to the literature and had to go back over 20 years to find anything about nurse suicide in the United States. At that time, I was conducting other research about workplace wellness. I did a study on the consequences of being blamed for a negative patient outcome, found that the consequences were similar to moral distress. Also tested a system for second victim support that was very well received by the staff. Well, during that research, I met Dr. Bill Norcross, who had been working on physician wellness for I don't know how many years, but UCSD, where I work, is only 50 years old, and he'd been there 45 of them. So he was definitely a giant here. And he and I were doing that caregiver support together when those nurses died. And I said to him, boys, there's got to be something to prevent suicides, prevent deaths like these, to recognize people who are at risk sooner. And he said to me, well, there is. The doctors had a problem like that, and 10 years ago, we developed a suicide prevention program for doctors right here at UCSD. We were the very first to do it. We did it in collaboration with the American Foundation of Suicide Prevention, and we've been running it ever since. We used to have one death a year, and now we haven't had one since. It'll happen eventually. We're not going to be that lucky forever, but it is stemming the tide of physician suicide. So I said to him, Bill, can we extend that to nurses and other healthcare providers? And really, the doctors, when we wanted to move forward with the suicide prevention program, they said, well, we never thought nurses were at risk. We never even thought to ask you. Shame on us. It didn't cross their mind that we might have needed the same kind of help that they did. We wrote a small safety grant. We asked for $14,000 to do a small pilot with nurses, and they gave us 10 times that amount and said, do it for the entire organization. Don't limit it to nurses, do the pharmacists and the other hospital staff as well. So at the same time that we started deploying the very first nurse suicide prevention program in the world, we also started studying the problem more in depthly about how much suicide is there amongst nurses.
You have such an interesting lens on this, as well as, first of all, thank you. Thank you. Thank you for asking that question. And then being so dogged about it. From this research lens that you have, and I think just a really heightened sense of awareness, COVID has really taken a toll on everybody. It seems like more nurses have been exposed to and caring for and being in the direct interaction, whether it's screening, whether it's treating, whether it's caring for, whether it's being at the bedside of somebody who is dying and away from their families. And the more I talk with nurses, that's what I hear, is that it's a traumatic experience by the volume, by the risk that they take to themselves, for their families, what they're seeing happen with patients, what they're seeing happen with patients' families, that extreme separation. Somebody gets picked up by EMS who's complaining of these symptoms, and they get taken to a hospital. That may be the last time they see or speak to that loved one. That's a lot to take on emotionally as a care professional, as a nurse. What are you seeing and what are you concerned about?
Before COVID, the work compression was horrible with all of the rules. We're overregulated. Overregulation decreases autonomy, and that's, again, another risk for suicide. Feeling as if you're helpless, you cannot get the work done in a day, that it's beyond you, you have no control. So I am hoping after COVID that the rules that have been loosened due to COVID stay away forever, that those rules no longer exist. If nobody died because we didn't follow those rules during COVID, we should take a hard look at those and just stop doing those things. Then I challenge every chief nurse officer in the entire country to take the students that come into their buildings to learn nursing and sick them on the policy manual and have them redline anything they can't find evidence for. And that's the way they can learn evidence-based practice. And take out every line on every standard and every policy that has no evidence to support it. After accreditation visits, CMS, the Joint Commission, all of those visits end up with somebody saying to the group of wise men at the organization, you need to fix this by tomorrow, or you're going to have a deficiency or a fine. And 10 wise men sit around a table and come up with a rule that is not evidence-based, but it gets the regulatory people off their back. Nobody takes those rules back out of the books. They stay there forever without any evidence to support them. I would challenge that one of the things we can do to help strengthen the workforce and build resiliency is to remove all non-evidence policies and statements from all the policy statements, the regulatory standards, accreditation standards. Get rid of them.
It's a moment in time where everybody across the world is focused on the exact same problem at the exact same time. Health systems have been under stress. Our healthcare workforce has been under stress, our economy, all of these things coming together. And it's a moment where we can really take a look at it collectively as well as individually. A lot of these systems are going to need to be rethought, rebuilt, and we need to be thinking about that in terms of resilience. You're expert in this. What do we need to do?
Well, we need to build resiliency training into the education and curriculum. My dear friend and colleague, Dr. Bernadette Melnick, has developed a cognitive-based therapy skills building program that works to improve resiliency amongst nurses. She's tested it in randomized controlled trial. It decreases anxiety, depression, and suicidality. And we know that these skills will work, so we have to commit to what's important and make sure that nurses have these skills. Jonathan Bartel developed this pause, and it was brilliant. You get 45 seconds after a patient's death to recoup and honor that person in their death, in their life, and everything about that experience. But isn't it sad that we think it's a win when we get 45 seconds? So I think we need to reframe our leadership training so that charge nurses give real breaks to people after a death, that somebody, your buddy, will probably talk to you and give you a little immediate debriefing. If you have peer supporters in the unit, they would be looking out for somebody that had a moment like that and tap them out to give them time to talk about it before they went on to the next task. You have time to do what you make time to do. Priorities are important. We have to make the mental health of the workforce a priority and of importance, just as important as getting a patient out of the ED. Because if we don't maintain our resiliency, we won't be strong enough to keep caring. The hope is, the good part is, there are things we can do. That's the good part. If we just take action. We just hired 2 more therapists to bolster our program to be able to brace for what we're going to find when we screen nurses now. Anyone can start one of these training programs. It only costs a couple $1,000s to put it together, and that's a drop in the bucket to a life of a nurse. Contact the American Foundation of Suicide Prevention, info@afsp.org, and you talk to them about setting up a screening program. They'll help you get it all encrypted so that the nurses can feel totally safe disclosing their mental health issues. This is how simple it is. A simple email saves lives. The chief nurse officer sends out an email. You're encouraged to do this as a matter of self-care. When you go on to do the screening, it goes through encryption to the American Foundation of Suicide Prevention. Those that screen moderate or high risk are funneled back to therapists that are internal to the organization. They start a conversation through the computer. They don't know who you are. You don't know who they are. You can break your anonymity at any point in the process, or you can keep it all the way to being referred to a doctor. And it works. And it works because it's proactive. It's a push. We don't wait for people to say, I need help. You need to couple a program like that with boots on the ground, looking out for each other. Everybody feeling okay to approach somebody who's under extreme stress and saying, you know, I care about you. Looks like you're having a rough day. You want to talk about it? That's actually a suicide prevention technique. Just recognizing somebody that's under stress and so they don't feel alone is a suicide prevention technique. And we can all do that with no money. We just have to start watching out for each other.
Judy Davidson is a nurse scientist at UC San Diego School of Medicine in the Department of Psychiatry. Shifting paradigms when it comes to mental and emotional well-being among healthcare workers has to start before nurses begin practicing. Pam Cipriano is the dean at the University of Virginia School of Nursing. We talk with her about embedding wellness into all aspects of nursing education.
I'm Pam Cipriano, a registered nurse. I am currently the dean at the University of Virginia School of Nursing. I'm also the first vice president of the International Council of Nurses, past president of the American Nurses Association, which was really an amazing opportunity during my career to be able to speak for the 4 million registered nurses in the United States. As a dean now, which is the first time that I've had a significant role in the education of nurses, where most of my career has been either in management of the clinical delivery of care or in leading the big discussions on behalf of nurses in the U.S. in my days with ANA. It is a different perspective, even just thinking about a couple months ago. That worldview was to recognize that nurses today have an enormous amount to learn and synthesize as we think about sending them out in the world. But the same issues that have been around from when I became a nurse, which is over 40 years ago now, still has to do with making sure that the public understands that nurses have a very rich and rigorous education, that they bring scientific knowledge to whether it's the bedside or whether it's novel roles that they've taken on or whether it's their community activism, that nurses bring a very well-rounded education and skill set. And yet they never lose sight of the need for that, again, compassion and caring and being able to address the needs of a patient and family. And that's actually a pretty tall order in today's world when we think about educating the new nurse. To me, there's a dual challenge, which is to make sure that nurses come out of any program recognizing that they are a significant force in shaping healthcare, that they have a huge role in advocacy to make sure that patients get the right care from the right providers, and that they speak up for them if something is not going in the direction they think is right. They have a responsibility to themselves to take care of their own needs and to protect their own well-being. So I think I was still formulating my worldview as the leader of an academic organization, really influenced a lot by what I bring with my background from the delivery of care and the policy leadership, being in nursing organizations my whole career. And so blending that together, really wanting to say the graduates from our school are going to make an impact. I mean, I can remember back to when I was a very young nurse, and you don't know this about me, but I was probably a much stronger activist than my current portfolio would demonstrate. Between my second and third years as a staff nurse, I went on strike. And I would never have envisioned being part of a labor action. But it was the right thing to do, as gut-wrenching as it was. And as we were criticized for not being professional, it was what was necessary to really make sure that nurses were respected, that we had the ability to control our practice, and that we were going to be influential in being asked to participate in decision-making that affected not only patient care, but really the role and scope of nursing in that organization. And that has always stayed in my memory as a really important part of I think, what shaped my knowing that you always have to do the right thing. And that if you take those steps, if you take that risk, you're never wrong. There will be times where the risk continuum says this is really scary, but a professional nurse does what's right.
With COVID-19, we're spending a lot of time talking about the massive disruption to healthcare, but there has been even the same level of massive disruption to learning. When we think about what's happened K through college,
right?
How we're having to rapidly reimagine and rethink, what is the learning? What is the curriculum? How do we deliver? How do we assess? And there are a lot of people who have said that education, particularly higher education, was ripe for disruption. None of us wanted it quite this way, but you take it as it comes. You have a unique role as the dean. So at that initial preparatory level, I would say I think a lot of the disruption needs to come from the faculty and our leadership. I'll just throw that out there. What do the faculty need to be doing differently so that we are actually preparing the healthcare workforce to respond to these ever-changing, unpredictable needs that they're entering into?
Yeah, Shauna, I think that is really the key for the future. You can't teach the kinds of experiences that people have been having during this pandemic if you're only teaching what's in the textbooks. And so many curricula, proudly, both here and other places, I can say, really have taken a look at the fact that we have to be teaching about leadership, we have to be teaching about ethics, we have to be teaching about how nursing influences the science of healthcare. And I also think that we have the ability to teach differently and be able to create experiences. Simulation has opened up that door. As for the faculty innovating, I think we have a continuum of faculty. We have those who love to do really unusual, creative kinds of things. And I do think the changes this spring have brought out the best in some of our faculty. Using gaming, using all kinds of ways to say, everything has had to change, so let's think about what we want to do differently, I think is an important part of recognizing the great responsibility that faculty have. The other flip side of that, though, is that faculty have to be really open to suggestions from their students. Today's students are so smart. It's great. And we don't want faculty to be threatened. And if we truly believe in lifelong learning and we truly believe in a learning health system, whether it's the education side or the practice side, we recognize that we're only going to get better and improve as we take on those ideas. And so I know that we have students that challenge all of us at different times. And that's how I think we all get better. And this is a time, as you said, to say, okay, what did we do that was really novel and exciting, and how do we make that stick? For us here at the University of Virginia, one of the things we have been doing for the last several years that I believe is truly paying dividends right now, and we hear it in the stories that are coming back to us from these nurses on the front lines, is that we have focused on self-care and resilience. And not that we were able to even conceive of creating the life experiences that they're going through, but we have had a cadre of learning opportunities through what we have here called our Compassionate Care Initiative. Students, faculty, staff, clinicians in our hospital have all been able to experience learning about resilience, learning about mindfulness, learning about how you incorporate all these concepts into becoming a better caregiver and really understanding that this is emotional work. And so you will have a toll that it will take, even the happy times. There will be an emotional part of you that you cannot ignore. And so as we think about the high levels of stress that nurses experience, we also have to recognize that there's a joint responsibility from wherever they're working, but also as individuals to say, my ability to take care of myself and to make sure that I do everything I can to stay healthy physically, mentally, emotionally, spiritually, is an important part of what we want students to leave their educational programs with.
You've really been vocal, and I thank you for this, for aligning up and talking about being a part of the Healthy Nurse, Healthy Nation. I mean, here we are, a caring profession. We know the science, we know the practice, we make recommendations to our communities that we care for all the time, and we're not the healthiest part of the workforce. We tend to be rather unhealthy, and it is related to the stress, the lifestyle. I mean, how is it that we're supposed to be healers and work in places of healing, and we're not so healthy ourselves as nurses? What is the Healthy Nurse, Healthy Nation campaign and program?
So HNHN, as it is abbreviated, is really focused on meeting the future goal of improving the health of the nation, believing that nurses touch so many lives. Now, if you do the math, nurses are just under 1.5% of the population in the United States. So that may sound like a small number, but when we think about the number of people that nurses talk to, there's the person that the neighbors and family members go to for advice. So we thought it was really important, especially knowing that nurses are not healthy. They don't sleep as well. They don't eat well. They have high stress. They're not as active as they need to be from an exercise perspective. So we said, okay, we really have a responsibility to help nurses be as healthy as they can. They, in turn, can influence their families, their friends, and ultimately the community and the country. Really appealing to nurses through social media, through engagement activities. Plus, we signed up employers. And the employers were already beginning to focus on how do I make my dollars earn more health for my employees. So it was an economic imperative for employers too, but fortunately they saw the benefit.
We've been facing across the globe a mental health crisis. For the most part, the vast majority of people across this planet, mental health is the biggest challenge. Isolation, loneliness. We do not have enough psychiatrists. We do not have enough psych nurses. We do not have enough facilities, and it's manifesting itself in self-harm, in suicide rates. There are just so many symptoms of a much bigger problem. COVID-19 has helped us to have a global conversation that says, how are you, really? And then given us an opportunity to talk about how we are feeling, how we are coping. And the issue of resilience, we've talked about flattening the curve from the standpoint of let's not overwhelm our healthcare system. We have seen where the vulnerabilities are. We've made some serious structural changes within how we deliver our health services. It's not all going to be in the hospital. We've asked people to stay at home. We're asking for social distancing. That's not going to go away anytime soon. So as we rebuild a health system and we think about it in terms of resiliency, we're going to have to start by building a healthcare workforce. And we've got a pent-up situation of a lot of trauma we're going to have to deal with. I'm asking you your thoughts around my supposition there, my assessment, seeing if you agree around this epidemic of stress that we're facing and what that might be. But What does that mean in terms of how we go about rebuilding or addressing the needs of our workforce to make sure that they are resilient so that we in turn can build a resilient healthcare system?
Well, you've cited all the background, very appropriately, and stigma is still one of the issues for people to put up their hand and say, I need help, or to actually have some kind of condition diagnosed. And that's a long-term issue. As a society, we have to be able to deal with that. But I do think COVID has really shined a spotlight on all of this. The good news is that about 2.5 years ago, the National Academy of Medicine convened the Action Collaborative on Clinician Wellbeing and Resilience. And it came from the fact that physician groups had finally identified that it was at a crisis level. And the percentage of physicians expressing burnout had reached about 50%. And so that really sounded the alarm. It's unfortunate that it took our physician colleagues saying they were in trouble to really get it recognized for the whole healthcare workforce, because nurses have been experiencing burnout for decades. I don't believe in the past it really got the attention that it needed. So the good news is that as a healthcare community, it's now getting significant focus. The Action Collaborative also then spearheaded the request to the National Academy of Medicine to do a consensus study, which was released last December, which allows the nation to take a closer look at all of these issues and to say, collectively, we've got to address this. Organizations have a responsibility. This is not something that gets put on the individual caregiver's shoulders. You can't just say, well, you have to tough it out. You have to figure out how to be resilient, or you need to make sure that you don't develop a substance use problem, because that's how it was looked at before. If you have a problem, you solve it. So now as a nation, I think we have the realization that we have created the settings and the scenarios where there is no relief from this intense stress and the intense emotional consequences. COVID has just upped the ante because of the amount of death that people are just not accustomed to dealing with. If it's in small doses, sure. An ICU nurse is very capable of holding someone's hand in their last moment. We know that where there is a high prevalence of that and it's repeated, such as oncology areas, that nurses have to truly take a break from that. So if we think about right now, the intense day after day after day exposure to nurses who are, and obviously other clinicians and helpers, who are being exposed to massive doses of tragedy and sadness and feeling like they just cannot be adequate. I mean, that's the ultimate moral distress. When a nurse or other caregiver says, I cannot do what I know is right, I just am falling short. And so I think we have a responsibility as a nation, and certainly leading from the healthcare community, to say we have got to provide that help and support. And it can't be one and done. It can't be, when the numbers go down, everybody will be fine. This will mirror true post-traumatic stress disorder. And so if we don't begin right now to recognize the consequences of asking repeated day after day exposure to these really difficult circumstances, then we will not do service to our nurses and other healthcare providers. And we need to teach nurses about it. We need to not keep it under wraps and say, well, once you're in the profession, you'll learn about these things or you'll see it, because it's one of those things that's not pleasant to talk about. I've often talked with classes of young nurses or orienting nurses and said, if someone told you all the negative things that you might experience as a nurse, you might get injured on the job. You might contract an illness. You might be subject to bullying. You might get fired because you spoke up and said this quality is not what it ought to be. If you knew that there were all of these risks that you were taking, would you become a nurse? What has always been really important to me, which is also inextricably linked to the intent of both International Year of the Nurse and Midwife, the activities in Nursing Now, and the annual focus on International Nurses Day, is that we want the world to know the contribution of nurses. We want the world to understand that without nurses, there's no healthcare. Without nurses, we cannot create a healthy world. And we have to have nurses stop being so modest about what they do We do need to have them tell their stories. We do need to have the link be made between highly educated individuals who not only are on the front lines, but they are doing so much behind the scenes that they don't get credit for. That makes the difference between someone returning to a quality of life that's meaningful, having their needs met, whether they are for restoring health or having a peaceful death, bringing together all of the factors that affect the inclusion of a family, or again, making sure that someone's wishes are honored. It is the nurse that is looking out for so many things that affect a patient's life, recovery, their whole experience, and yet they are behind the curtain. They are not recognized for that. And the thinking behind really focusing on nurses globally, I think, was to say we are the ultimate team player to the extent that we don't ask for recognition and we don't elbow our way to the front of the line. And part of that, we know historically, comes from being a gendered profession, being willing to accept less pay for the same work. For me, what's really important is getting an understanding in the minds of all people, but most importantly, the really big players that are making decisions, the health ministers in their countries, which for us is the Secretary of HHS and all of the agency leads. We want to be equal players. We want to be part of the decision-making set of leaders until we instill that in more and more nurses. And some of that will happen with aging out of individuals who were raised at a time that was not appropriate behavior. And some of it, though, I think has to be a conscious effort to say, as we are moving to a team-based environment, this is the perfect time to recognize the valuable contributions that all team members make. In some countries around the world, nurses are the only person in a community that has anything to do with health, that teaches families how to stay healthy, teaches them how to prevent illness, teaches them how to have healthy children. We're so fortunate in the U.S. We have more nurses per capita than any other country, and we have a pretty advanced education system. We should be leading all of these efforts to really make sure that nurses occupy the position of respect and influence that is absolutely critical for us to make the kinds of headway that we think is important.
Pam Cipriano is a distinguished nursing leader who has held executive positions in healthcare systems, academia, and national professional organizations in her career. In 2015, she was named one of the top 100 people in healthcare and one of the top 25 women in healthcare, both by Modern Healthcare magazine. Barbara McLean, Liz Stokes, Judy Davidson, and Pam Cipriano are all healthcare leaders with a different lens on the shared mission of building a healthy, happy, and resilient healthcare workforce. We've been hearing many stories from nurses on the front lines of this coronavirus pandemic. A common thread has been the high levels of stress they are experiencing in a healthcare system that was already very strained. And the key message throughout all of these stories is urgency. Moral injury, survivor's guilt, and burnout are all symptoms of a mental health pandemic among our nation's nurses, and one that cannot be overlooked or forgotten once this virus is under control. Celebrating the heroic efforts of the healthcare workforce by cheering each night is meaningful and deeply appreciated. But honoring their humanity, sacrifice, and risk by protecting their mental and emotional and physical health will come when that appreciation is followed by valuing that same workforce in our budgets as well as with our words. For See You Now, I'm Shauna Butler. Thanks for listening. And when I say thanks for listening, I mean thank you for listening.
Johnson & Johnson is proud to power up nurse-led innovation that is transforming health outcomes through skill building, leadership development, and more. The American Nurses Association ignites and celebrates nurse-led innovation to redefine quality nursing and advance healthcare for all. Subscribe to the podcast and learn more at seeyounowpodcast.com.